This is Dr. Tom Dombrowski recording Chapter 1 of Weber and Kelley. In order to define what is assessment in nursing, first we need to define what is nursing. And according to the American Nurses Association, the highlight of the definition is that it's the diagnosis and treatment of human responses. In other words, medicine diagnoses and treats specific diseases, whereas nurses diagnose and treat their responses to those diseases. So in order to make that a little more clear, let's imagine that you have two patients and both have cholecystitis, which means an inflamed gallbladder. One of those people is ambulatory, is eating and drinking, maybe has some pain, but is able to eat and drink and carry on normal activities. The other one can't hold anything down, has trouble walking due to not only due to the pain, severe pain, but she had trouble walking in the first place and now it's worse. And she's also incontinent of urine. So as a nurse, your care plan for those two patients is going to be very different. They both have the same medical diagnosis, but they're going to have different nursing diagnoses and different care plans. And the ANA definition of nursing goes on to state that this diagnosis and treatment of human responses should be assessment-based. So review the ANA definition of nursing, which is found on page 1 of the textbook, so that you have it clear what nursing is as opposed to medicine. And that will help clarify what the nurse's role is in assessment. There's much more to be said, and we'll be saying it in future slides, but begin with reviewing that ANA definition of nursing. So, next thing to consider, why do we do assessments? And nurses are not the only ones, of course, to do assessment. Physicians do assessment, and respiratory therapists may do assessment, and various other healthcare professionals do assessments. But one of the common factors is that we all do assessment in order to make some sort of judgment about care of a patient. So that's our basic reason for doing it, is to make a clinical judgment that's going to drive a plan of care. In the case of nursing assessment, assessment is actually the first step of the nursing process. We'll be talking more about the nursing process later in this presentation. And as we mentioned in the previous slide, assessment is one of the things in the that the ANA says that our nursing diagnoses should be assessment based. And so our professional organizations and also the regulatory organizations such as the Texas Board of Nurse Examiners hold nurses accountable for doing assessments. So it's part of the professional and legal standards of our practice. Now, the nurse's role in assessment has evolved over time, just as the healthcare system has evolved over time. If you go back to the beginnings of nursing as we know it in the late 19th century, early 20th century, nurses often relied on their natural senses. They did not particularly use instruments at that time. They may have had a few instruments that they could use to measure things with patients, but mainly they were using their natural senses, like, oh, the patient is breathing rapidly, he seems like he's short of breath, and this sort of thing, or his color is pale, or smell, or all of the senses that you can imagine came into play. And Florence Nightingale writes about this sort of thing using, as she put it, changes in color, temperature, muscle strength, use of limbs, body output, and degrees of nutrition and hydration. As the healthcare system progressed and as nursing progressed, why, instruments such as, ways of measuring blood pressure, and then more sophisticated things became more and more readily available, and the healthcare, the speed, if you will, of healthcare increased over time too, where in the past, in Nightingale's time, for example, there was really little in the way of treatment options, and if the patient seemed to be getting worse, perhaps you would summon the physician, and you'd probably have to send a messenger for him. In that case, in that time, it was almost always a him. But there may not have even been a telephone communication possibility. You might have had to send somebody to summon this physician, and CPR was unknown at that time too, so there wasn't a whole lot anybody could do when the patient took a turn for the worse. Contrast this with today, when we have instant communications. We have a huge array of technologies to do all sorts of tests and gather all sorts of information on the patient, and sometimes due to this increase, due to this expansion of technology, a lot of responsibilities have been given to us as nurses that were not given in the past. Now we would initiate, if we see the patient has expired, rather than summoning the physician, we would initiate CPR, for example. And because of this expansion, many times decisions have to be made, and the physician cannot personally come to the hospital at that time, so she or he is going to be relying on our report in order to drive her or his plan of care. And then our plan of care is something a little different. I mean, we have a nursing plan of care and the physician has the physician's plan of care, but the two have to be very closely related and congruent, and not be at odds with each other. And so if you consult look at box 1.1 in the textbook, and you'll see a short snippet of how assessment has evolved, how nursing assessment has evolved over the last 100 years or so. So, as we mentioned, assessment is the first step in the nursing process. And the nursing process is something you're going to become very well acquainted with, not only in this class, but all your other classes as well. And we lay it out as a nice, neatly defined circular process going from assessment, diagnosis, plan, intervention, evaluation, and back to assessment. But really and truly, a lot of times there's a little more overlap there, and you may be at various stages. You may be assessing one thing as you're actually doing interventions for another problem that the patient has. Be that as it may, the thing to keep in mind is that it's not like you're going to go in and just assess, and then when you finish that you'll diagnose. It's an ongoing and continuous process. And assessment is the key to it, because if each step depends on the previous one, like if you make a mistake with diagnosis, your plan is not going to be good, your interventions won't be good either. And so therefore assessment is of vital importance, because if you don't collect good assessment data, why then the rest of the whole process is not going to go well. So Weber and Kelley have a framework for assessment that they present, and this is the way they organize not only this chapter but all their chapters. They're going to start with the history of the present concern, meaning that you gather information which is going to be from the patient. This will be just what the patient tells you, or whoever, if their patient does not speak for herself or himself, whoever brings the patient in and speaks for them. But they're going to tell you the present concern and the history of it, how it began, how it's evolved, what other things they have done previously to try and solve the problem, etc. So that's history of present concern, such as, oh, I'm here because I broke my arm. Okay, well, how did that happen? Well, I was tried to get up and I fell, and when I felt this horrible pain and I couldn't move it after that. Okay, well, when did this happen? Oh, about 2 hours ago. And so that would be, all that sort of thing would be history of present concern. Personal health history would be things like, have you ever been hospitalized before? Have you ever had surgery before? Are you current with your vaccinations? That sort of thing. Well, that could overlap with lifestyle and health practices, that last one, but things about personal health history would be other previous encounters with the healthcare system. Then family history, we're going to mainly be looking at blood relatives here, but what have your specifically siblings, parents, grandparents, what medical problems or health problems have they had in the past? And this accomplishes several things. For one thing, many diseases have a hereditary component, and so this is going to help us evaluate the patient's risk for various diseases. And finally, lifestyle and health practices. We'll be particularly concerned with things like smoking, alcohol, street drugs, and then other things too about lifestyle, eating patterns, bowel patterns, urinary bladder patterns, things like, and health practices. You may think that everybody just follows recommended health practices, but you'll soon discover that there are people do a wide variety of things for their health, some well-founded and some not. Like you might say, well, what do you do to prevent illness? Well, I try and maintain a good diet. And what does that mean to you? Oh, well, I know I only eat hot foods when I have cold diseases, and eat cold foods when I have a hot disease. And that's not something that's scientifically founded. It may be something that the person learned from her or his family, or it may be culturally related. But those are all things that are going to go into our assessment. You'll be hearing a lot about evidence-based practice, and certainly we want to base everything that we do on evidence. Unfortunately, there are some traditional healthcare practices that the evidence is not, the evidence is just not there, but in those cases we go with expert opinion or what seems to work. One of the things we're doing, we besides preventing disease, we also want to promote health. So as nurses, we're not just about reacting to diseases. We want to be proactive and help people stay well. And there's a couple of nursing theories that are widely used and that are important in health promotion activity. One of them is the health belief model, and the other is the health promotion model. Pender is one of the authors in both of those models. The health belief model says that whether or not you're going to implement a health practice that's recommended depends on your motivation, your perceived vulnerability, and your perceived benefit. So, in other words, if I have a patient that has high blood pressure and I tell her, well, why don't you cut down on your salt and see if that helps your blood pressure? Whether or not she does that is going to depend somewhat on her motivation, like does she really want to reduce her blood pressure? And then her perceived vulnerability. Does she believe that the bad things she's heard about hypertension are really going to affect her or not? And then perceived benefit would be, does she believe that cutting salt is going to actually help lower the blood pressure and help protect her from all those things? So if for example, if motivation might be affected by, I don't know, maybe she just got divorced and she's depressed about that, and she says, what's the use, I might as well die anyway. So the motivation would be lacking there. Perceived vulnerability, maybe she's young and she feels like all that stuff I'm talking about heart disease and strokes is only pertaining to older people, and so it doesn't affect her. And then the perceived benefit of it, maybe her mother gave up salt and it didn't do her, it didn't help her any, so why should she try it? And so that's the health belief model. The health promotion model is closely related, and it says that the three things that are important there is individual characteristics of the person, their cognition that's behavior specific, and their level of commitment to doing the health promotion activity. Then types of health assessment. We have four basic types. The supplemental text, the Doyle and McCutcheon, has the same four basic types. They use slightly different terminology for them, but they're still the same four types. So the first one is the initial comprehensive assessment, then ongoing or partial, then focused or problem-oriented, and then emergency assessments. The initial I'm got ahead of myself there. Initial or comprehensive. This is an assessment of all body systems, and it involves first taking a past health history, then a family health history, lifestyle and health practices. That's all the questioning part. And then you do objective data. You do assessment findings like what we call head to toe. You're assessing all body systems. So this is typically done when the first person first comes into a care setting, like if it's a hospital, that would be done on admission, and it may be done at periodic intervals as well. Like you would typically do this, say when depending on hospital policy, you might do it once a day or once a shift, or do a comprehensive health assessment. But you would definitely do it when the person first came under your care, or not necessarily your care as as an individual nurse, but under the care of the system that you're involved with. Partial or ongoing assessments are what you would do in between, where when it supposes you've already done a comprehensive initial assessment and you identified certain problems. So you would do a short overview of body systems, and you would reassess the problems detected earlier, and also do like a mini head to toe to detect any new problems. So in your comprehensive initial assessment, maybe you spend an hour doing that, and you identify, say, a respiratory problem and a heart problem. And those are the problems that you're going to be working with. Then in your partial or ongoing assessment, you will focus in, okay, how is that respiratory problem doing? Okay, that's improved. Now what about the heart problem? Well, still no improvement in that one. But then you would also do, you wouldn't ignore the rest of the body. You would just kind of briefly go over the rest of the body and say, oh, we have a new problem here. We have a problem with urination. And then that would bring us to the focused or problem-oriented assessment. Say you did discover a new problem with urination. Well, rather than doing a complete comprehensive assessment again, you're going to do a thorough assessment of urination, of your genitourinary system. The other time you might do a focused or problem-oriented assessment is if you are working in a specialty clinic, like say the GI lab or somewhere like that. So they may have a routine focused assessment for that area. So the person that comes has already had their comprehensive assessment done when they were admitted, and then they come down to the GI lab for help with a specific, I don't know, a specific procedure or something like that. So you would focus on the gastrointestinal system there. And then lastly, emergency assessment. So as the name implies, this one is done when you have a life-threatening situation. It's rapid, but we're as thorough as we can be under the circumstances. But your focus is on airway, breathing, circulation. That's your ABCs. So if you did remember your CPR training, you do assessment as part of CPR. It's a very short assessment, but it's vital and it's there. Same thing with other types of emergency assessment. You may, for example, have a situation of chest pain and you think the person is having an MI. So your assessment is going to be focused on the same things. Airway, are they breathing? Well, yes, they're breathing. Do they airway? The airway's open and they are breathing. Circulation, well, okay, we may have a problem with circulation, so we're going to do some cardiac enzymes and EKG to rule out or rule in an MI. and then that will be the focus. The focus of that assessment is uh, the immediate life-threatening emergency, and so those are the 4 different types of assessment. Now, steps of the assessment process. First is preparation, and this will be the way the chapters are organized in the future too. Preparation, then collecting subjective data, collecting objective data, validating, and documentation. Preparation is going to be involving what information you have available. Like most of the time you won't, unless you're working in emergency room in triage, you won't be getting people with absolutely no information at all. You'll probably have some sort of information from whoever's handing over the patient to you, or from previous encounters if it's a clinic, or you'll most likely have something there. So if you have time before the patient even arrives or before you go in, spend a little time reviewing the chart. Then you'll want to get necessary equipment together based on the information you have. Why, you'll know that, well, okay, I'm going to be focusing, this assessment's going to be focusing on respiratory issues, so I'll want to make sure I have a pulse oximeter, and so various equipment that you might need for that assessment. And then finally, preparing self, particularly if it's an emotionally trying sort of thing. Like if you know your patient is an alcoholic and your father was an alcoholic, and you are mad at him still, and you still have issues related to that, you'll want to spend a little time preparing yourself to be non-judgmental with the patient. Subjective data is anything that the patient or someone tells you, as opposed to things you see. Like objective data would be things you see, hear, touch, know through your own senses. But subjective data is going to be what they tell you. And so we have biographical data, like where do they live, where were they born, maybe, occupation, that sort of thing might be all that kind of thing might be on the biographical data. History of present concern, we already spoke about that, but that's going to be important. And try to get away from, like, there's a tendency a lot of times, by the time they get to you, why, you may say, oh, well, what brings you here? Oh, cholecystitis. And it's like, well, the patient didn't just wake up and say, oh, I have cholecystitis. Somebody has obviously told them they have cholecystitis. So then you say, well, what happened? What made you first come to the emergency room? Oh, well, I was having nausea and pain in my abdomen. Where? Oh, okay. Where was the pain? Can you point to it? And so then, so try to get to the behind when they say, like, when they try to give you a medical diagnosis. Now, sometimes you'll have somebody say, oh, I'm here for my COPD. And you say, well, how did you, what were you feeling? How did you know you had COPD? Oh, I've had COPD for 10 years. So then, that would be another situation. That person has had repeated episodes of the same thing, and so she or he can probably teach us about COPD. They did wake up and knew that they had a exacerbation of COPD. Then the next thing in subjective data, we'll ask about their personal health history. And many times, if you have a record available, you can supplement it, what they tell you with that, and probably go over it because there's lots of errors in those records. Errors creep in. So ask them about that. But yeah, it's good to have that record available, and that way, because otherwise, like a lot of times they'll say oh, I've never been sick, I've never been in the hospital, and then you look and say, well, okay, it says here that 2 years ago you had your appendix out. Oh yeah, I had that. And then it says that before that you had a broken arm. Oh yeah, that's right. So if you can supplement those two sources, and then sometimes too the family can help you with that too, because like they'll be telling you, well, I've never been in the hospital, and then the wife will be saying, well, honey, remember you were in 2 years ago, for etc. Then family health history, depending on agency protocol, we usually go back to grandparents, and we would do, as I said, we would do siblings, parents, and grandparents, and if they had any significant diseases. And so the way, as you'll see when you do the genogram, you would document, like, say, a sister that's 45 living and well would just be 45-year-old L/W. And then a parent, say a father who died of a stroke, would be at age 68. You'd put father deceased at 68 of CVA. And then health and lifestyle practices, depending on which system you're focusing on, it would be what things you would be looking at, but most all the systems you'd want to know about smoking, drinking, street drugs, and possibly what healthcare, what they have done about their problem prior to coming in. Like they may, well, I tried to do some over-the-counter medications, but that didn't work, so I decided I better come to emergency room. Then turning to objective data, remember that's going to be anything you detect with your senses as opposed to what they tell you. So that could be physical characteristics. It could be something you see, like their color or their rapid respirations or the color of their sputum, a smell. Maybe sometimes there's a characteristic smell of liver disease called hepatic fetor, or maybe you smell alcohol on their breath, or maybe you smell tobacco, a strong tobacco smell on their breath. Body functions, which would include things like breathing. Maybe you observe that they're urinating in a diaper or something. Their appearance, their general appearance, and behavior that you observe. And then, of course, all kinds of measurements that we do, whether we're measuring height, weight, pulse rate, temperature, etc. And then lab tests, as well as other tests such as X-ray, CT scan, etc. So by the time you've gotten to this point, you have a lot of data, some of it subjective, some of it objective, and maybe there will be some conflicts there. Like maybe what the patient might tell you, well, no, I don't smoke, and you smell strong tobacco smoke on them. So you'd want to resolve the discrepancies, and maybe the patient tells you, well, no, I don't smoke myself, but everybody in my house does, and everybody I work with does, and it's so you'd want to resolve discrepancies. And then also identify what data is missing. We'll be talking more about validation in Chapter 4. And then documentation, which we'll also be talking more about in chapter 4. And it is the basis, documentation is the basis of your database, that the chart, the medical record, have you, or what have you. So your documentation is going to go into that and form the basis of not only your own care planning, but possibly that of other members of the healthcare team. Because that chart is shared by everybody, so that some things that are gathered by the nurse, for example, maybe the vital signs, if you don't put in accurate vital signs, maybe the physician is going to be relying on the vital signs you put in, and maybe she will come to an improper conclusion based on your vital signs. So, and then besides that, this proper documentation will help ensure that valid conclusions are made during the second step of the nursing process. Then in analysis, we synthesize the data. We identify possible nursing diagnoses, collaborative concerns, or referrals. Collaborative problems are problems that you're going to continue as a nurse to be working with, but you need input from a different profession, so you're going to collaborate. Referrals, you as a nurse are not going to be involved anymore. We'll talk about that more in later process, in the later videos. And then the analysis is going to involve the critical thinking process, which has 7 steps, and we'll be covering that in chapter 5. Some of the factors that affect assessment are the context of the patient. Like you may see a patient someday that you are thinking, oh, that person is dysfunctional. She is really, her life is really messed up. And it may be that she is living in the midst of a very dysfunctional situation. So it's not that she's dysfunctional. She may be functioning as well as possible in the context of the situation she's living in. So you want to take those broader factors into account, factors of culture, family, community. And sometimes you don't have that information right away. Sometimes that will become apparent later on as you're caring for a patient.